So I just want to do a quick, just kind of map out here the basic windows so we're all on the same page, recognizing that we're from a variety of backgrounds, and some of us with a lot of training and some of us with a little bit of training. So this is just a quick review of some basic windows so we can all understand the approach to how we look for, identify, and classify pericardial effusion. And I always say the best windows in an ICU patient are the ones you can get. And this is often the case because patients, sometimes you can't move them. They can't be moved to a lab or to a CT scanner, or you can't move them in the bed at all. And so the nature of critical care ultrasound is about being opportunistic.
They're usually the windows you cannot get, actually.
Yeah, well, in some cases you may not get any windows at all, and that's certainly the case. But it's really learning about how to really exploit those windows in patients with certain conditions. Like, for example, on patients who are mechanically ventilated, oftentimes the subcostal window or the subxiphoid window can be a very useful and accessible window, and it's also very fast. So first, covering the parasternal lung axis view. This is obtained with the probe at around the 3rd or 4th intercostal space in the left peristernum. If I can draw our attention to the right side of the screen of the actual echo image, the top portion is the RV, or what often called the right ventricular flow tract area. You have the left ventricle here, which is in the midfield area. Mitral valve, which is displayed opening, and then in the middle of the image you can see the aortic valve, which is displayed there. And in this case, the distinction is that this is a normal parasternal lung axis window. Okay, this is relatively good normal function, but also what's more important here is the lack of something being seen, and that is an anechoic space or a dark space surrounding the heart, in which we'll go on to discuss. But that's a window which I hope you guys can use as a kind of a reference standard for what would be a normal parasternal lung axis window. Parasternal short axis is with the probe rotated with the marker towards left shoulder. Okay, and so that's more or less left peristernum with the marker towards left shoulder. And now we're getting more of a cross section of the LV, where the LV should be a circle. It should be a circle in systole and diastole. And there are a few points, but just to really abbreviate it down to the important points, we can look at, this is the mitral valve level, and this is the papillary muscle level. And so, again, the reason I want you guys to really focus on this window is what we're seeing and what we're not seeing. What we're not seeing, again, is that anechoic space surrounding the heart. So this is your kind of normal reference standard for your cross-section or your parasternal short axis. Okay, apical forechamber. Again, to orient you, left ventricle. This is with the probe and the marker towards the bed. Okay, and so that's commonly they can either be supine or left lateral decubitus, but this is it's most often near the apex, or a little bit inferior and lateral to where the left nipple would be. And in this case, we can see the left ventricle displayed screen right, the right ventricle here, left atrium. So this is our, again, reference standard. We don't see any obvious anechoic space surrounding the heart. And so this is, again, would be a normal apical forechamber. And one of the very common views we use in critical care would be the subcostal forechamber. One of the often easiest to access, as long as there's not a whole lot of gas in the stomach, frankly. But in this case, what we're seeing in the most superior portion is often next to the liver. That's the right ventricle. Obviously, that being the right, this would be the left ventricle. Left atrium is at the bottom of the screen there, and right atrium is to the left. So again, this is there might be a small pericardial effusion here, a small little anechoic space, but this would be likely irrelevant. So again, that's your normal subcostal forechamber, which is obtained with a probe just below the sternum and with a marker toward the patient's left-hand side and going underneath the sternum. Here's your subcostal view. And so just to orient you guys here, this is with the probe marker oriented towards the head. Okay, and so the beam is crossing in a sagittal plane with the marker towards the head. So in that case, we can see the right atrium displayed screen right. You can see the IVC emerging from the right atrium and the hepatic vein coursing perpendicular to the IVC. That's a very classic view that we're used to seeing, and it courses through the texture of the liver. And that's the important part. So there are kind of three distinguishing features. It goes to the course through the texture of the liver. You have the hepatic vein emerging perpendicularly, and it enters the right atrium. This can be commonly confused with the abdominal aorta, which is oftentimes courses, obviously doesn't connect to the RA, and it's surrounded by hyperechoic intensities, which is often fat. So that's the IVC view, and then in real time we can see displayed here through the texture of the liver. We can see it connect to the RA. It often can be pulsatile, so that feature doesn't help you distinguish between the abdominal aorta. So that's your IVC view.